what I'm going to do is just for the first kind of 20-25 minutes, just give a broad outline of how I report to Sinus CT, and then got a few kind of 9 or 10 cases which are quite interesting, which are probably the best part in terms of take-home messages. So I'll freely admit I don't, relative to temporal bones and other head and neck, this is not my favored kind of area, but they kind of our staple diet. So what do I do with the Sinus CT? So I'm going to just tell you how I approach reporting them, give you a few little kind of reporting tips, potential pitfalls, and as I said, I've got a selection of cases that we can go through just to show you some relevant pathology. So how I report it, I keep it quite simple really. So we'll divide it into right and left, and then divide it, look at this, first off the drainage pathways. So looking at the anterior sinus drainage pathway, so that's mainly related to the frontal sinus and the frontal sinus drainage pathway. The ostiomeatal unit, so that's looking at the anterior ethmoidal labyrinth, maxillary sinus, and then we'll look posteriorly at the posterior ethmoidal air cells, sphenoid sinus, and the sphenoidal recess. So I keep it simple, just comment right and left, anterior, posterior. So how do I start? I always typically start with the frontal sinus. So you guys are probably more au fait with some of the classification systems, and you guys are getting real life feedback whenever you do FES in terms of all these anatomical variants. What do? I will first comment on aeration of the frontal sinuses, right and left. I'll freely admit, don't really use classification systems like the London Mackay scoring systems. We will typically give a kind of subjective confirmation as to whether there's mild, moderate, or severe mucosal thickening, whether it's completely opacified, and what's the density within the sinus, the contents. When I start with the frontal sinus, so this is the relevant anatomy. Here, this patient, nicely aerated frontal sinus. You have this kind of frontonasal process, the kind of inferior aspect of that frontal sinus, and here, frontal sinus drainage pathway. And then I will typically just divide it into anterior and posterior frontal ethmoidal air cells. You have the various kind of type 1 to 4 classification systems, but I typically will just divide it into kind of anterior and posterior frontal ethmoidal air cells. And in this patient, you can see nicely patent frontal sinus drainage pathway. So this is just a slide for lots of the different anatomical variants that you're going to encounter. So as I said, it's easier just to simplify it and divide it into kind of frontal and posterior frontal ethmoidal air cells. So here, asterisk there on the most anterior, the agonase air cell, and here you can see in this patient there are some additional frontal air cells that are more superior to this. Remember, you've got this kind of type 1 to 4 classification. Some of them with the type 4s, you've got additional air cells. In this patient, this is completely opacified, and you can see in this patient you have compromise of that frontal sinus drainage pathway and this type 4 frontal air cell. And then we'll then go posteriorly in terms of the posterior frontal ethmoidal air cells. Again, here you've got the ethmoidal bulla, and we'll comment typically if they're kind of suprabulla. You can see here this kind of got the suprabulla, and here this kind of frontal bulla air cell, which is adding to potential compromise here in this patient in terms of the frontal sinus drainage pathway. I don't typically put a lot of anatomical variants. We'll suspect our sinus CT surgeons are much better than I am. There are a few variants I will comment on. So firstly here, just to outline, you can get these additional supraorbital ethmoidal air cells, and I tend to comment on these mainly because of the relevance in terms of the anterior ethmoidal artery. So I will typically comment whether I think the bony channel for the anterior ethmoidal artery is simulated into the anterior skull base, or if it's surrounded by either aerated or opacified air cells, mainly because of potential risk of injuring the little channel and then causing an intractable intraorbital hemorrhage. So this is one of the anatomical variants that we'll always comment on when I'm talking about the frontal sinus drainage pathway. Then as I move on, we'll then typically comment on whether the frontal sinus drainage pathway shares the same kind of drainage pathway as the ostiomeatal unit. So that relates to now moving on to the ostiomeatal unit, looking really at the uncinate process here. So looking as to whether that uncinate process will attach to the orbital wall, or whether it attaches to the anterior skull base or the kind of nasal septum turbinates. So you can see in this patient, you can see the uncinate process here attached to the medial orbital wall. So this frontal sinus drainage pathway goes directly into that middle meatus, and the maxillary sinus and anterior ethmoidal air cells will drain separately. So this allows you to explain some of the patterns of sinus opacification. Similarly, different patient. So here you can see that the uncinate process here is attached onto the anterior skull base. So you know that frontal sinus drainage pathway has the same kind of drainage pathway as that ostiomeatal unit. So it can explain some of the various patterns of sinonasal opacification. So that's how I start. Look at the frontal sinus drainage pathway first, along with the kind of anterior posterior frontoethmoidal air cells. We'll also then, when I'm looking at the frontal sinus and the drainage pathway, comment on the anterior skull base. Our surgeons don't really ask us to comment on the Kiros, but as you're aware, it allows you to tell the surgeon as to how low the cribriform plate is, and whether you've got any, whether it's particularly low lying in a type 3, or whether it's further high up with a type 1. And as I said, I typically always comment on the bony channel for the anterior ethmoidal artery. So one of the other check areas when you're looking at the frontal, kind of that frontal area and the anterior skull base, this is one of my check areas, is always to look at this olfactory niche. So it should be nicely aerated. So in terms of the anatomy, there's the crista galli, you've got the cribriform plate, the lateral lamella, and here you can see the top aspect of that nasal septum. You've got the turbinate there, and you have this olfactory recess or niche that should be nicely aerated. And you can see little defects here. That's where the olfactory nerves will run through. And in here you can see there's a little blob here. Now on a CT scan, you have no idea what that is. That could just be a polyp, a little bit of mucosal thickening. But this patient had nasal discharge from the right side. I'll show you the MRI when we look at some of the cases. So this is one of the areas we'll always interrogate. And here, similarly, another patient, but with more extensive opacification here. So as the radiologist, you know your surgeon's going to pick up on these changes. What am I going to do as a radiologist to help my surgeon? The main thing is then to look at the bony structures. So here you can see orbit here, lamina papyracea, and here, as I said, the review area, you can see these olfactory recesses, these niches are opacified. And the other thing here is I want to be able to see my bony landmark. So there's nasal septum, cribriform plate, lateral lamella, and here is not quite so clear cut. So you'd be worried here that there's something going on with the anterior skull base. Bearing in mind the caveat that when you've got the opacification, these are very thin pieces of bone, so sometimes it can just be partial voluming. But if you're ever worried, I will typically overcall this and recommend further imaging with MRI that will then tease out whether this is simple, banal mucosal thickening or whether there's a sinonasal mass. So this is the same patient, just going to move on to the MRI. So this is that same patient. So here you can see, you can't really make out that cribriform plate, lateral lamella, and you can see when we did the MRI, there's a lot of secretions here within that maxillary sinus, sphenoid sinus, but actually within the superior aspect of the nasal cavity, there's this enhancing mass. And the reason that cribriform plate is difficult to see is because that mass had extended up into the intracranial compartment. So this is a coronal T1 post-contrast. You can see nice kind of dark fat here in the orbit, so that orbit's intact, but here with the sinonasal mass, it's gone up into the intracranial compartment. This is all abnormal dural enhancement, and that mass has traversed that anterior skull base and gone into the anterior cranial fossa. Now, from a radiologist's point of view, there's kind of a huge list of potential sinonasal masses. I don't try and second guess kind of the underlying pathology, but your job as a radiologist is to mark out, is there a mass, yes or no? And then to guide your surgeon in terms of spread of that mass. So whenever you've got something in the nasal cavity, so making a landmark, so how much of this is mass, how much of this is retained secretions, has it gone, for example, laterally into the orbit, has it gone to the contralateral side, and has it gone superiorly up into the intracranial compartment? So that was just to recap, again, looking at the olfactory recesses and olfactory niches. Once we've looked at the frontal sinus drainage pathway, I kind of touched upon it. I'll then focus on the anterior ethmoidal air cells, maxillary sinus, and looking at the ostiomeatal unit here. So again, this is not your normal patient. This is nicely aerated, completely normal. Most of your patients won't look like this, but here, maxillary sinus, that's the maxillary sinus ostium. Your kind of, as you can see here with the drainage pathway, you've got the hiatus semilunaris, the infundibulum there, that's all nicely aerated. Ethmoidal bulla, and you can see there frontal sinus drainage pathway all clear, and in this patient an additional variant with a little concha. So once you've divided the anterior into the posterior ethmoidal labyrinth, the best way to do it is to look in two planes. So here's the coronal plane showing you that uncinate process, and then if you look at a sagittal plane, you can see the lateral attachment of that middle turbinate will then subdivide your anterior ethmoidal labyrinth here from the posterior ethmoidal labyrinth. And you can see here this patient nicely aerated. Then once, as I said, to recap, so how do I divide it into anterior and posterior sinus drainage pathways. So I'll comment on frontal sinus drainage pathway, then the ostiomeatal unit, and then I'll move further back, looking at the sphenoid sinus ostium and the sphenoidal recess. So this is where it becomes a bit more interesting for the friendly radiologists, so particularly when you've got an opacified sphenoid, always be very cautious. So lots of neurovascular structures. So one of the things we'll always comment on for our ENT surgeons is relationship to the optic nerve canals, looking at the the neural foramina. So you have the Vidian nerve canal, the V2 division, the trigeminal nerve, and also importantly, the pathway of the internal carotid artery canals. Sometimes you have little bony septations, areas of dehiscence, and particularly when you've got an opacified sphenoid, there are lots of causes for this. So not just mucosal thickening, there's a whole list of the checklist that the radiologist will go through to help you. So this is an example. So when I move further back, so you have the posterior ethmoidal air cells here. You can see sphenoid sinus nicely aerated, looking forward, and in this patient, they've got a nice aerated sphenoidal recess. Here you've got a little variant. So we have different classifications. I still call them anode air cells, but really the kind of these posterior ethmoidal air cells that can run above the sphenoid. So we'll always forewarn the surgeon whether I think there's an anode variant and the relationship to the sphenoid, particularly its relationship to the optic nerve canals. And remember, again, there's various classification systems you can use. I will typically flag up if I think there's any bony dehiscence or potential risk of injury to the optic nerve, but there's, you guys may be familiar with the Delano classification. My job really as a radiologist is to kind of flag up any kind of suspicious opacification of the sphenoid. So here, same patient, you could easily just walk past this and think this is just a bit of sphenoid kind of opacification, sinusitis. But my job is to spend a bit more time looking at the bones here. So you can see here, opacified sphenoid. Can't really make out, is it right or left? Probably you can see there's some remodeling there. So that's probably on the left side, the left sphenoid sinus drainage pathway. And then if you reformat this onto the sagittal planes, you can see here that the bony margins, particularly here on the posterior aspect of the clivus, is not clearly defined. So whenever you've got opacification of the sphenoid, you want to kind of try and find the internal carotid artery canals. So here, they look normal. On the sagittal view, look at the pituitary fossa. Can I see the pituitary fossa? Because lots of things can cause sphenoid sinus opacification. It could be a pituitary tumor, could be carotid artery aneurysms. And here you can see actually this patient had a midline lesion, which is causing bony destruction. So this was not mucosal thickening, but this was a tumor that had gone anteriorly into the sphenoid and actually was a chordoma arising and going forward. So just kind of tip there, always be very cautious when you've got an opacified sphenoid sinus, specifically if it's particularly isolated. And I'll come and show you examples of other things that can cause it, but be wary of internal carotid artery aneurysms, cellular tumors, meningiomas, chordomas, etc., and the meningocele that I'll show you in a moment. So once I've looked at anterior and posterior sinus drainage pathways, we'll go on to the nasal cavity. What am I going to look at? Nasal septum. Is it intact? Yes, no. And is it deviated? And lots of different patterns of deviation. I will typically comment on nasal septal spurs as well. Some of my colleagues don't, but I will comment on degree of deviation, bony spurs, and if there are any perforations. And my job really is if there's mucosal thickening, commenting whether any of that mucosal thickening is irregular, because sometimes a nasal perforation could be a marker of more aggressive processes that you guys are all aware of. And we'll then comment on some of the turbinate variants, contrabulosi, etc. So other thing, just to summarize, once I've looked at drainage pathways, nasal cavity, nasal septum, when do I think of neoplasia? I've shown you a few examples that I'll show you some of the cases. Bony appearance is really the key as a radiologist. So trying to delineate whether you think there's bony remodeling, pressure erosion, or whether you think there's a more aggressive pattern of bony destruction. Typically, if you've got a unilateral pattern of sinus disease or opacification, and our clinicians will tell us if they've seen anything suspicious or patients who are really non-responsive to medical therapy. So this example in point, this patient was bouncing around with left-sided nasal obstruction, and you can see here quite clear that this really, you've got a kind of pan opacification here of the frontal and posterior ethmoidal labyrinth. You can see here frontal sinus, maxillary sinus sphenoid. So you've got a unilateral pattern of sinus opacification. On the right side, completely pristine, little turbinate variant there, concha bullosa. So is this suspicious? Yes, because it's unilateral. And then I'm going to look at the bones. So in this patient, again, similar to the other case, if we recap, that's the olfactory niche that I mentioned before. You've got the cribriform plate, lateral lamella, cristogali. So here, can't really make out that cribriform plate. And that lateral lamella is definitely suspicious. That's gone. So that was, I'll show you when we go through the cases, that was anesthesia neuroblastoma. Similarly, here again, pattern here, the patient's got a unilateral right-sided maxillary sinus opacification. Going to look at the bones, and here the surrounding bones are actually intact, but here you've got a little bony outgrowth here. So that as a guide for some of you, so when you've got unilateral opacification here, this little kind of bony outpouching raises the suspicion that there's an inverted papilloma. We did the MRI in this patient, and you can see here this cerebriform appearance that was an inverted papilloma, and that was the kind of bony attachment that you can sometimes see with these tumors. Okay, so then once I've looked through the sinonasal compartment, I'm fairly aware that most of my sinonasal surgeons are better than I am in terms of assessing some of these, all the anatomical variants and appearances of the paranasal sinuses. I will typically spend more time as a radiologist looking at some of the other things. So this will all be on a sinonasal CT. So always looking at your orbits. Have you got kind of normal laminar papyracea, looking at your optic nerve canals? You'll always capture part of the nasopharynx. So always looking at the kind of soft tissue component that we get with our sinus CTs. And then looking at some of the other skull-based structures. Sometimes you'll get the maxilla included. So always looking at your maxillary dentition. And you'll always capture part of the temporal bone and the TMJs with your sinus CTs. So lots of ENT structures here when you do your sinus CT that we'll spend a lot of time looking at. So that was just a quick introduction as to how I report them. So now for some of the more interesting stuff. So I'm going to show you a few cases where we'll apply some of that. So I'm going to start off firstly with this case. So if you remember anything from this 45 minutes is this case. So this is what we drum home into our radiology SPRs. So this, in terms of history, this was a patient who had a bone marrow transplant, was unwell, facial pain. So what I'm going to do is just go through the axial bony views first. So particularly when you have any kind of anything on the form with a sinus CT that says immunocompromised, there's always one thing that you should be wary of, and that's an invasive fungal infection. So I'm going to show you how that presents radiologically and what to look for. So here, if you can see, you've got mucosal thickening through some of the paranasal sinuses. You can see here, particularly when there's active inflammation, we typically radiologically, you'll see these bubbly secretions, potential fluid levels. So everything looks fairly banal so far, but actually if you're going to be very wary with invasive fungal infections, a couple of things, people will always, one of the misconceptions is with the sinus contents that it should be hyperdense, but that's not always the case. So you can see here there's possibly a fluid level there, there's a opacification. So there are various different patterns of fungal infection, as you know. So we can see sometimes what we call the mycetoma or the fungal ball. So that will be very bright white or hyperdense on CT. The other thing is sometimes we see allergic fungal sinusitis. So that typically you'll get that with polyposis, and you'll get this kind of sheet-like hyperdense material. And then this is the other end of the spectrum. This was a patient with an invasive fungal infection. How do I know that? I'm just scrolling through. So the key with invasive fungal infection is to look at fat planes. So as radiologists, you'll hear this term saying fat's our friend, and this is why. This is the CT scan on the soft tissue window setting. So your CT scan, as you know, has got various different densities, the bright white being the bony structure, intermediate grays are soft tissue structures. So here, for example, with the orbit, the optic nerve sheath complex, the rectus muscles, orbit, and then this dark stuff, which is the intraorbital fat. So I'm just going to maneuver this a bit further north. Okay, so whenever you've got an invasive fungal infection, you need to spend time looking at fat planes. So which fat planes do I look at? So firstly, I'm going to look in the orbit. So particularly looking at the orbital apex. So there's your orbital apex. And you can see I'm going to deliberately show you the normal side first. So you should always have fat packing within your orbital fissures. So orbital fissure there. And then you'll see how that goes into the inferior orbital fissure. And then it tracks inferiorly here into the pterygopalatine fossa. Now that should have a few little vessels and it should be packed full of fat. Okay, then we go further north, just to recap. Orbital apex, you've got nice intraconal fat, orbital fissure, full of fat, pterygopalatine fossa. One of the other areas to then look at is always in the retroantral location here, posterior to that maxillary sinus. You can see here, beautiful clean fat there. Premaxillary location again, nice, beautiful, clean fat. So now if we look at the contralateral side, you can see how that's slightly different. So if we look at the orbital apex, so there's the optic nerve sheath complex you can see. And as you go further south, if we come into that orbital fissure, you've got a bit of asymmetry there. It's filled in. So that's not the normal dark fat that you're seeing. It's filled in with this material. That's probably the best example. I'm going to magnify it just to emphasize the point. Nice clean fat. This is all dirty fat. And you can see here, as we come onto that pterygopalatine fossa, you can see how that's nice clean fat, and that is all irregular. So this, particularly with invasive fungal infections, remember you don't have to have much in the way of bony destruction. The angioinvasive, they can spread along vascular channels. Here, thankfully, it hasn't really spread into the retroantral location. Okay, so this is an invasive fungal infection. Then actually, if you look at the bony structures, you can see in the region that's sphenoid, there's some bony changes that you can see. So if I go further north, okay, there's the pterygopalatine fossa, slightly rarefied. And then as we go further north, if you compare right and left, that sphenoid wall is intact. And here you can see it's slightly rarefied. So again, when you see this as well, you're going to flag that as radiologists, we drum it home into our trainees. You always got to get on the phone, speak to your ENT surgeon, particularly if this patient's immunocompromised. These patients can deteriorate rapidly. And the other thing we typically advise is further MRI imaging, because you want to know if this infection is now, the fact that it's gone into the sphenoid, there's some bony erosive change, whether it's gone into the cavernous sinus, and whether you've got intracranial spread of the fungal infection. So that was an invasive fungal sinusitis, and the key was looking really at the fat planes. Right, the next case I'm going to show you is, again, this is just to show you just to put as much information as possible for your radiologist. So this is typically when you've got absent structures in the sinonasal compartment, there's always a tendency to think the patient's had previous sinonasal surgery. So if we're going to, this is in the axial view, we're going to show you on the bone windows. You can see there's some mucosal thickening there, that frontal sinus recess, anti-ethmoid layer cells. And then as we move further south, you can see there, we've got the normal septum. The normal septum is missing. You've got a septal perforation. The other thing you can see is you don't really see bony destruction, but you've got this irregular bony change that you can see here. So this is this really irregular osteitis, kind of fluffy bone formations. So you've got this irregular osteitis within both maxillary sinuses. You can see there a bit of some poor dentition as well. And as you move further north, you can see, just to reiterate, some of the nasal turbinates are not there as well. So just going to show it. This is preferred view, I think, for the ENT surgeons. If you're coming through in the coronal view, you can see there's your perforation. The other thing is you've got some missing structures here. So this is the inferior turbinate you can see on this side, can't really make it out on the contralateral side. And you can see the other thing is the difference between kind of benign kind of mucosal thickening and this, which is, the surface is slightly irregular, and you've got, as I said, all this kind of reactive osteitis, and you've got destructive changes. So the way I'd report this is now comment saying that there's an aggressive sinonasal process. So the differential would be, you'd want to know if there's any kind of history of illicit drug use, cocaine snorting, anything like that. You'd want to know is there background history of granulomatous process, something such as sarcoid, or other kind of vasculitis, so there's ANCA-mediated vasculitides that can cause this pattern. This patient did have, I'm not supposed to say vagueness anymore, so they kind of, this patient had a proven vasculitis, and you can see how you'd flag that up there. You've got middle turbinate, and you can't see it on the other side. So when you've got missing structures within the sinonasal compartment, septal perforation, attenuation of the turbinates, irregular mucosal thickening, as well as this pattern of kind of bony change, always think of something more than just rhinosinusitis. Think of a more aggressive sinonasal process. And in this case, this was a vasculitis. It's I'm going to show you next case. So this was, as actually this patient self-discharged. We don't know where he is, but he came in following a trauma. And then it turns out from his history that he'd had episodic epistaxis. So you can guess where I'm going with this. This is the axial CT on the bone window. So as we come down, the patient had a soft tissue injury there. You can see over the front of the frontal bone. And then as you come down, you can see nicely pristine, nicely aerated sinuses. Okay, and as we come further south, you can see there's some soft tissue opacification here. Okay, so particularly when you've got, in terms of the demographics, this is quite a young patient. So you can see, I'm going to show you on the soft tissue windows in a moment, but you can see there's some soft tissue there, normal right sphenoid here, abnormal kind of left sphenoid, this kind of lobulated soft tissue. The other thing is the bony changes. So you can see here, if we go back, there's the pterygopalatine fossa. So you can see how this is remodeled, the posterior wall of that maxillary sinus. You can see how it's remodeled the pterygopalatine fossa, and you've got this kind of bony destruction here. This is the pterygoid bone. You can see there's some erosive change on some of those pterygoid plates. Just going to show you on the soft tissue window. So in a youngish patient with epistaxis, the thought is whether this is a tumor, and particularly whether this is a kind of juvenile angiofibroma, because this is the typical location, and this is how we see it on a scan. We've got soft tissue that's typically centered on the sphenopalatine foramen that I'll show you. Go back to the bony landmarks, just showing you on the soft tissue window here, just to show you how you've got normal pterygopalatine fossa here, abnormal, this expansile soft tissue. So this typically remodels the pterygopalatine fossa. There's the normal sphenopalatine foramen on the contralateral side. That's the kind of typical epicenter of this tumor. And you can see how it's spread inferiorly. And sometimes these tumors can be quite aggressive. They can go further north. They can get up into these orbital fissures, go up into the intracranial compartment and destroy some of these additional bony structures at the orbital apex and go further north. And then just to recap, so particularly if you've got a soft tissue lump or bump that's posteriorly located, again, looking at the bony structures, and particularly if you've got a young adult male patient with epistaxis, one of your check areas is going to be that sphenopalatine foramen. I'm going to show you what it looks like on the bone window here. So as you come further south, there's the pterygopalatine fossa, there's the sphenopalatine foramen, and you can see here abnormal soft tissue lump at that site with bony destructive change. So that was a juvenile angiofibroma. Okay, halfway through, got another kind of 15-20 minutes. So, okay, this is to recap on one of the take-home points about sphenoid sinus. So this patient had intermittent kind of nasal discharge. They'd also been seen in neurology clinic as well, I think, from what I remember. Okay, just gonna. Okay, so this is just to recap. So they had intermittent discharge from the right side of the nose. I'm going to go back just to show you the coronal view. You could walk past this, looks fairly okay. So if we show you the coronal view here on the sinus, okay. So this is just to show you again. This was, for those of you who recall, this is the patient, the slide I showed you earlier. You can see there's the normal anatomy, there's the Christogali nasal septum, cribriform plate, and you've got a little blob here. Okay, you can see actually you've got further little outpouchings in the anterior skull base, and if you go further back, you can see further little outpouchings here. This patient was slightly more robust, and they had papilledema and actually had idiopathic intracranial hypertension. And then if you're never sure about what this is, typically we will do an MR sinuses, and the key sequence with the MR sinus really is, if you get one sequence, is to look at the coronal T2 weighted sequence. So this is a coronal T2 weighted MRI, and why it's useful is because it allows you to work out kind of what's mucosal thickening, what could be soft tissue mass, and in this patient here with that olfactory niche opacification, you can see this patient, if we look at the brain tissue, that's the gyrus rectus, that's orbitofrontal brain parenchyma, and you can see how this is almost sucked down or hoovered down further south, and this was a meningocele, and that was the cause of the intermittent nasal discharge. It was a CSF leak from the anterior skull base, and we do see a lot of these in patients who've got idiopathic intracranial hypertension, and they often have lots of little outpouchings. You can see this is not an entirely normal anterior skull base. So even if you repair this, they can potentially crop up CSF leaks at other sites. So that was just to recap in terms of looking at the olfactory niche. And if you're ever uncertain, I typically have low threshold for doing MRIs. It's very useful in terms of working out what your problem is. Okay, this is another patient which was helped with the use of the, I'll show you the MRI in a moment. So, all right, so, okay, so this patient actually presented with problems with visual loss in the left eye, symptoms of nasal blockage on the left side as well. So this was the sinus CT that was performed first off. So if we start off, frontal sinuses look okay, and then you can see this slightly odd opacification. We've got a normal ethmoidal labyrinth on that side, and you can see here slightly odd opacification that you can see, which is involving the sphenoid, involving the turbinate, and if you go further north, you can see that ethmoid looks abnormal, involvement of the anterior skull base. You can see the cristogali looks abnormal. Again, for the benefit of, I'm speaking to ENT surgeons on the whole. This is the coronal view of the same patient. So if you come further back, there you can see got a normal turbinate on that side. This turbinate is abnormal. You can see that ethmoidal labyrinth is abnormal. Cristogali looks abnormal. As you go further back, you've got this abnormal anterior skull base. And in terms of the visual loss, there's the right optic nerve canal that again doesn't look entirely normal. All of the sphenoid looks abnormal. And on the left, if you follow it back, there's the orbit, there's the optic nerve canal. And again, you can't really make out the optic nerve canal. So your question here, this all looks rather odd. It's determined whether you think this is a problem with the sinuses, or whether you think, given the extent, whether it's something related to the skull base. So I'm going to show you the MRI next. So this is the MRI sinus that we then did. So again, I'm going to show you the coronal T2 weighted sequence first off. So there's your globes, there's your optic nerve sheaths, there's the optic nerve, and you can see coming back, difficult to follow at this point. And this is the sphenoid, which looks really irregular. This is a T2 weighted sequence and some irregular, really low T2 signal chains that you can see. And as you go further forward, just other anatomical landmarks, there's the cristogali. That's your olfactory bulb and tract. Okay, so you can see CSF, there's the olfactory nerve and bulb. Okay, so you wouldn't be surprised if the patient also had problems with their olfactory system. So this, if we go back, this patient was quite young. She's a young female patient. The optic nerve involvement was because you've got this abnormal intrinsic skull base process, and this has a slightly ground glass appearance. So this was not a problem with the sinuses per se, but actually was a problem with the bones. And this was a young patient with fibrous dysplasia. So this is the typical pattern that we see on a CT, is this kind of ground glass opacification. So they can often present with problems with the cranial nerve dysfunction, mainly because it can narrow some of the skull base neuroforamina. And it can look slightly odd, and often, particularly with visual symptoms, you can see here how that problem was, unfortunately, she's had a decompression, but she lost vision in the left eye and has got poor vision in the right eye. But you can see how that can be explained by this intrinsic skull-based process that was affecting the optic nerve canals. All right, going to move on. Next case, so this was, okay, so again, okay, so this patient chipped up, had been seen actually with very odd history of recurrent seizures. So they'd seen a lot of neurologists over a period of quite a few years. So if I start with the sinuses, you can see here, frontal sinus is not really that well developed, it's slightly small. You can see the ethmoidal labyrinth. The reason they came to an ENT surgeon is because they also developed right-sided nasal discharge. So you can probably see where I'm going with this. So you can see here that maxillary sinuses, frontal sinuses, anterior ethmoidal labyrinths fairly clear, but actually you can see that there's a problem here in the right sphenoid. So again, if you remember, always be cautious when you've got an opacified sphenoid. So what's my checklist? What do I go through on a scan? Firstly, I want to try and find the internal carotid artery canal. So there you can see the canal coming through. So you've got the bony canal is intact. You can see the same on the other side. Okay, so that is not, it looks like it's a normal carotid canal. So the opacification I wouldn't put down to an aneurysm. What am I going to look at next? I'm going to look at the back end, particularly that example of the chordoma that I showed you. Look at the back end of that clivus going up into the posterior aspect of the sella. So you can see there's the pituitary fossa. So that bony margin is intact. So again, I don't think that's coming from the intracranial compartment. The clivus all looks intact. Again, use a sagittal reformat, double check. So here you can see you've got a normal pituitary fossa, normal posterior margin. So it wasn't really anything coming from the pituitary fossa itself or within the intracranial compartment behind the clivus. However, I'm going to come onto the coronal view next. So I'm going to go anteriorly. So other relevant anatomy. So there's globe, there's your optic nerve canal. You can see that's intact. There's this opacification that you can see. The other structures that are relevant here, you've got this is the V2 division of the trigeminal nerve. And remember, the Vidian nerve canal is inferior and medial. There's the Vidian nerve canal on that side. Much harder to spot on this side, it's probably slightly exposed. There's the V2. And the other thing that you've probably noted now is the opacification. Where else could it come from? So always be very wary of meningoceles, meningoencephalocele. So here you can see there's a defect here in that middle cranial fossa. So you can see in terms of guiding the surgeon, in terms of if anyone's going to go and repair it, this is lateral to the pathway of that V2 nerve canal. And you can see this is going to be a very difficult area to get into. This is right snuck up into that pterygoid recess. There's the normal left sphenoid. Okay, nicely aerated in here. You can see there's some loss of the bony coverage. What are you going to do? You want a little bit more comfort. So we're going to do an MRI. So again, this is a coronal T2-weighted sequence again. So if we start anteriorly, you've got normal globes, normal orbit. This is optic nerve canals, normal brain. And you can see we're starting to creep on. This is very hyperintense material. Okay, and I'm going to leave it on this slide. So this is a normal temporal lobe. So this is kind of your mesial, temporal lobe, and uncus. Okay, and you can see here that this temporal lobe is slightly distorted. I'll show you again on a T1 weighted sequence. And what had happened, the reason they'd gone to the neurologist is because they developed a defect in the skull base. They developed a meningoencephalocele, and this was all abnormal brain tissue that could form a focus for seizure activity. And because they had this meningoencephalocele, they had an intermittent CSF discharge that was proven positive for beta transferrin. Again, if you want to look at be entirely definitive for your surgeon into whether it's just a meningocele, so with a meningocele, it's just the meningeal layers that you see, or encephalocele when you start to have brain tissue that herniates through. So you can see here, normal temporal lobe here, and here you can see some of that temporal lobe has been sucked in. You've got brain tissue that's gone through that skull base defect. Okay, so that was all from a unilateral kind of opacified sphenoid on that first CT. All right, I've got a few more cases, but it's gone on for about 40 minutes. What I might do is just do one very final case. I'm happy to show when I've made mistakes myself. I think trying to remember this. This was a child. This is just when you can get caught out as radiologists. This was a very final case. So this was a young child who presented. I think it was a query whether this was a preseptal and orbital cellulitis. So the kind of thought this is all a kind of infectious process, but actually here you can see with this child, you can see the sinus is abnormal, but you can see there's some bony remodeling here. So I put this down to an acute infection, but actually this is a long-standing process with some bony remodeling. So I'm going to show you a few sequences just for anyone in the audience. It's a kind of a quiz as to what they think it is. You can see this is a child quite young, so some of the paranasal sinuses haven't developed. You can see all this opacification, some bony remodeling, and then I'll show you the MRI, which kind of clinches the diagnosis. So this was the T2 weighted sequence. So you can see the young brain, and you can see here, there's the right orbit, and you can see here, there's some little fluid levels. Okay, so this is an MRI. This is almost pathognomonic of a certain bony lesion that we see. So this was sold as a kind of query orbital cellulitis, but this was quite a young child and had the proptosis had been there for a little while, and you can see here this was a bony lesion with multiple fluid levels. So I don't know if anyone wants to hazard a guess on the chat as to what they think this is in terms of the underlying diagnosis, but just the take-home point was always being very cautious in terms of looking at bony structures. What I've overlooked in this case is the fact that this has been remodeled, and this actually turned out to be an aneurysmal bone cyst, which is difficult to treat and will often recur. Okay, so I think I'm going to end it there. So that was just a kind of summary of how I report sinus CTs. The main thing was some of the cases, particularly the invasive fungal infection, kind of the making sure you check the olfactory recess, looking at sphenoid sinus, and then looking at bones. That's the key for a radiologist when we're looking at these sinus CTs. You'll often go through a lot of polyposis and rhinosinusitis. Your job as a radiologist is to tease out the kind of suspicious and aggressive cases. Okay, so I think that's...
Thank you very much.
Right.
There's some really clear slides, really helpful in terms of describing common and rarer pathologies, and a really systematic approach to interpreting scans. Someone's asked about, can you comment on odontogenic sinusitis appearances, please? Do you have anything on that?
Yes, I do. So, hold on, let me go to the... I've got a case here, which is an OPG. So, yes, I do. So, often we'll try and get some of your patients out of the... so, for example, what's the key? I will typically... typically, when you're doing sinus CTs, you should always get your maxilla and all of your maxillary dentition on there. And yes, you can comment on whether you think sinusitis is odontogenic. So typically what you'll see is often it'll just be a kind of sinusitis within the maxillary sinus antrum. So as a radiologist, we will spend a lot of time looking at, this is an example of someone who's got maxillary sinus problem due to a tooth, but we'll typically comment on whether you've got periapical lucencies, whether you've got caries, different pattern of caries, and typically if you've got just mucosal thickening in the antrum, one of the things you're going to comment on is the integrity of the alveolar ridge. So if the bony ridge is gone and you've got a carious tooth and you've got mucosal thickening, that's when I'll typically start to flag as to whether this is maxillary sinusitis. And as you say, and as you know, you don't really want to operate on maxillary sinusitis when it's been driven by a carious tooth. You want to have the dental findings addressed first. One of the other things to be wary of is when you've got an opacified maxillary sinus. So this patient will show you, this is what can happen once you've had a dental extraction. So here, if you're scrolling through that, you might think, well, actually, that's maxillary sinus opacification. One of the things is always to look for little thin bony rinds. So you can see there, I don't know if you can appreciate, there's some remodeling there. Yeah, so you can see a thin line of bone. Okay, so this is not maxillary sinusitis. This was on the OPG, the sinus was opacified, but actually they'd had a dental extraction and it was a residual cyst that had increased in size. So yes, in answer to your question, I always comment on whether I think sinusitis is related to the teeth. Be very careful about some of the opacified maxillary sinuses. They can be secondary to dental problems, as in this patient, they had a dental extraction and there was a residual cyst that gradually got bigger with time. And I'm no OPG expert, but that's what you see. This was the opacified sinus and they had a previous dental extraction, so that residual cyst had got bigger and bigger and they had right-sided facial pain. Does that help?
Thank you, that's brilliant.
The key is when you guys are looking, should always have all of your maxilla, all of that maxillary dentition on your CT sinus scan.
Great. Can you show any scans demonstrating the nasolacrimal duct?
What pathology or?
Well, someone's just asked for the anatomy.
Yeah, I mean typically what we'll see, we've seen a few infections. I don't think I've got any available to hand, but the nasolacrimal, as you know, I'll show you the two views. So often it's kind of split the screen for you. There we go. So on a coronal view, you'll see it nicely, and often, sometimes it'll be partially filled with tears, so you get a lot of variation in terms of whether it's opacified. So there, you can see there's the nasolacrimal duct. Okay, so you can see a little bit of aeration. Okay, and then sometimes it's full of tears, and as you know, it will creep down and open up into that inferior meatus. So what pathological states do we have? I've seen a few cases of kind of infections which destroyed the bone. The other thing is if it becomes remodeled or destroyed, you often will see that either with a sinonasal tumour that's spread up the nasolacrimal duct, or vice versa, you've got an orbital or skin cancer or tumour over the top that's gone into the nasolacrimal duct. So it can be a pattern of spread of tumour. This is what we'll often see. And in East London, we see a lot of trauma. So particularly when I see craniofacial trauma, if I see a fracture line that runs through the nasolacrimal duct, which you can see there, I will typically comment on it. Sometimes the patient will develop scarring and they'll present a few months down the line with epiphora. So I'll always comment on whether I think that's involved. And it's probably for you guys not easier to see when you've got a coronal view. Go anterior to the orbit, there's the nasolacrimal canal, and then you can see how it opens up to that inferior meatus. So typically the main situations where I will comment on is trauma, whether we've had a couple of tumours that have gone from the orbit down the nasolacrimal duct, and in terms of, yeah, as I said, kind of any sinonasal tumour that's gone the other way around. But you'll often, if it's a pacified, it's not always abnormal, so it can be full of tears or it can be aerated at the time of the scan.
Thank you. I think this is our last question. So in pansinusitis, will you be able to identify the presence of a supraorbital cell?
That's difficult. The reason why is when you, I'll show you, when you've got a complete pansinusitis, often your thin bony landmarks go, so then it becomes really difficult. So let me just pull up a sinus that's full of gunk. Hold on. Yeah, in answer to your question, no, it can be very difficult because you won't see the internal bony septations that you need to work out different anatomical landmarks. Let me just pick on this case. So for example, when you've got an opacified, this probably shows you beautifully the fact that you can't tell. So particularly when you've got a pansinusitis and this is all opacified, particularly some of these thin bony septa you're going to lose. So in terms of working out where your agenesia cell is, ethmoidal bulla, supraorbital, can be really difficult. Even here you can see there's the bony channel for the anterior ethmoidal artery. So in answer to your question, when you've got a pansinusitis, it can be very difficult, and no, not always, you can't make out.
Great. Well, thank you very much.